So my personal experience has been limited because in my center we have isolated completely our hematology unit from COVID. So no massive tests to patients in hospital, and from patients who were admitted to my unit were done in order to avoid any COVID positive patient inside my unit. But I have conducted a survey throughout Spain in order to know the impact of COVID-19 on ALL patients. And we have found 28 patients infected by COVID during the peak of the pandemic. So it was in March, April, and mid-May. So it was the peak of the maximum incidence of COVID, and at that time we located these patients in several centers from Spain. The main result of the patients is that there was no specific subset of ALL with a particular higher incidence of COVID, but COVID-19 tended to involve elderly patients. So the median age was let me check, but the median age was about 50 years. So is really a higher age than that is expected for patients with ALL. So this is one of the things, and the other thing more important for me is that the mortality was high because 1/3 of the patients died by COVID. So most of them after being attended in an intensive care unit. So it's the mortality, it's clearly higher than that of the general population. That are the main data. The symptoms of COVID infection were the same as the general population, no differences. The treatment was the same, and really another important thing is that there was a trend for poor survival in patients with a low number of absolute neutrophil count and a low number of absolute lymphocyte count. It was related to the probability of death. Really, from this survey, we look at two situations. Those patients who were during the most hard chemotherapy phases of ALL, in these patients, ALL therapy was stopped. But when the patient was receiving maintenance therapy, for example, and then was infected by COVID, the therapy did not change. So these are the two patterns of therapy for ALL. Some patients acquired COVID after transplantation. So the treatment didn't change because the patients were transplanted. No further therapy was given to these patients. And in some cases, the COVID infection occurred during the rescue therapy. And in these cases, the rescue therapy was stopped also. That's what occurred. It depends on the period of the therapy of ALL in where the patient acquired the COVID infection. Well, it was really a massive decline on the performance of allogeneic stem cell transplantation in Spain, especially transplantation from unrelated donors, because the product, the donors outside Spain didn't donate, or the product was unavailable to arrive to Spain. So there were some limitations in this area. And the same occurred with CAR-T therapies. CAR-T therapies, the manufacturing process was also stopped. So it was a big impact on the transplantation and cellular therapies. Once we have recovered from COVID, we are now recovering time and making massively transplantations, because we cannot delay excessively the timing of transplantation. That's what we are done now. I think that it has been a hard experience, especially for some centers in which a massive COVID infection occurred. For example, in my center has 800 beds, and at the peak of the pandemics, 600 of beds were occupied by COVID-infected patients. So it has a big impact on the functioning, in the normal functioning in the hospital. So fortunately, we could attend all patients inside our unit with these special circumstances, but it was really hard for us, for people, for patients, for relatives, because relatives could not visit the inpatients, and it was really an extremely anomalous circumstance, and has a big impact on our day care for the patients. Fortunately, the pandemic is solved, not completely, so it's very important. The virus is here, and there are some little peaks today in Spain, and we have to be aware in order to not come back to this extremely hard period.